Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be talking about vasoplegia syndrome after cardiac surgery. I have no conflict of interest in regards to this presentation. Please take a moment to review the disclaimer for this talk. The agenda for today includes definition of vasoplegia, description of the pathophysiology of cardiac surgery-related vasoplegia, to review some of the clinical risk factors for vasoplegia, and discuss the management and pharmacotherapy. Let's answer a question. Which patient has vasoplegia? Patient number 1 has a mean arterial pressure MAP of 60, central venous pressure or CVP of 7, SV, which stands for stroke volume of 50 milliliters, and heart rate or HR of 72. Second patient, MAP of 55, CVP of 8, SV of 70, and heart rate of 100. Patient number 3, MAP of 52, CVP of 15, stroke volume of 32, and heart rate of 100. And patient number 4, MAP of 64, CVP of 25, stroke volume of 40, and heart rate of 60. Please pause the video if you need more time to answer the question. And we'll review the answer in a slide or two. But the correct answer here is option number B or 2, which is MAP of 55, CVP of 8, stroke volume of 70, and heart rate of 100. So what is vasoplegia? It is typically associated with systemic hypertension, such as mean arterial pressure less than 65, preserved or increased cardiac index and output, typically defined as cardiac index more than 2.2, low systemic vascular resistance or SVR, typically defined as less than 800 dynes, and the patient requiring high dose of vasopressor, for example, norepinephrine more than 0.2 micrograms per kilogram per minute. So let's review the answer to the previous question. Like mentioned, option 2 was the correct answer. In order to answer this question, you have to first calculate the systemic vascular resistance or SVR, and the formula for SVR is 80 times MAP minus CVP divided by cardiac output. You will also need to calculate the cardiac output in order to derive SVR. So cardiac output formula is heart rate times stroke volume, and in that particular patient it was 70 times 100, which is 7 liters. So the formula for SVR for that particular patient is 80 times 55, which is MAP minus CVP, which was 8, divided by 7 or 7 liters, and you have your number 537 dynes. And remember from the previous slide, low SVR is defined as less than 800. So this patient has reduced SVR and hypertension and meets the definition of vasoplegia. So why do we care about vasoplegia? First of all, it's quite common in the cardiac surgical population, so we see this a lot. It is associated with increased morbidity and mortality, especially when the case of vasoplegia is prolonged or refractory to management. The pathophysiology of vasoplegia syndrome is very complex. Vasoplegia is basically a multifactorial pro-inflammatory syndrome due to surgical trauma, ischemic reperfusion injury, exposure to cardiopulmonary bypass circuit, blood transfusion, depletion of vasopressin stores, and desensitization of vasopressor receptors, such as, for example, norepinephrine receptors. And all of this leads to upregulation of nitric oxide and other pro-inflammatory cytokines, such as interleukin-1, interleukin-6, and tumor necrosis factor, which all lead to profound systemic vasodilation. On this slide, you see a pictorial highlighting different aspects of the pathophysiology of post-cardiopulmonary bypass vasoplegia. Please take a moment and review different factors responsible for this syndrome. Let's do another question. Which of these patients is not at risk for vasoplegia? Patient number 1 is a 44-year-old male who has a history of intravenous drug use and he is scheduled to undergo tricuspid valve replacement. Patient number 2 is a 65-year-old male who is scheduled to undergo coronary artery bypass graft surgery. Patient number 3, a 52-year-old male who is scheduled to undergo reduced sternotomy. And patient number 4 is a 65-year-old female who is scheduled to undergo durable left ventricular assist device placement. So again, which patient is not at risk for vasoplegia? Pause the video for a moment if you need more time. And this is a tricky question because all of these patients, as you will see soon, are at risk for vasoplegia. So all of them are at risk for vasoplegia. Let's do another question. And here we ask you which patient is at the highest risk for vasoplegia. Patient number 1, a 65-year-old male with end-stage renal disease on hemodialysis who is on lisinopril, and he is scheduled to undergo redo CABG and mitral valve replacement. Patient number 2, a 34-year-old female who is scheduled to undergo tricuspid valve surgery for infective endocarditis. Patient number 3 is a 54-year-old male who is scheduled to undergo CABG. Patient number 4, a 56-year-old female who is scheduled to undergo aortic valve replacement. Again, like we learned from the previous question, all of those patients are at risk for vasoplegia, but patient number 1 is at the highest risk of them all because it's a reduced surgery and a complex operation of redo CABG and mitral valve replacement. On this slide, we'll go through some of the common risk factors for post-cardiac surgery vasoplegia. Again, the more risk factors you have, the more likely your patient is to develop it. Again, if you remember the previous question, we had a reduced sternotomy and a complex operation of a CABG and a valve. So this patient, by definition, has the highest risk of vasoplegia, like we mentioned. But again, duration of cardiopulmonary bypass typically exceeding 180 minutes, redo operation, valve surgery, CABG plus valve, heart transplantation, LVAD surgery, patients who have heart failure with reduced ejection fraction typically defined as less than 40%, patients with end-stage renal disease, patients with anemia, and patients who take certain medications in the preoperative period, such as ACE inhibitors, calcium channel blockers, beta blockers, diuretics, heparin, and amiodarone. Again, most of our patients in the cardiac surgical arena receive heparin. Again, by itself, it's a risk factor for vasoplegia. So what about the approach to management of vasoplegia? It is important to confirm the diagnosis and rule out concomitant problems such as hypovolemia, cardiogenic shock, and tamponade. It is essential to note that a patient can have more than one problem leading to hypotension, such as, for example, cardiogenic shock and vasoplegia can coexist. The treatment includes judicious use of IV fluids, first-line vasopressors, second-line vasopressors, and adjunct medications. First-line vasopressors include norepinephrine, which acts via alpha-1 and beta-1 receptors. The dose is typically from 0.01 to 0.5 micrograms per kilogram per minute. It has some inotropic activity, and some of the side effects include arrhythmias, cardiomyopathy, which is typically more pronounced with high dosing of norepinephrine, and organ ischemia. Vasopressin acts via V1A, V1B, and V2 receptors. The typical dosing for continuous infusion is from 0.01 to 0.06 units per minute. It has a long half-life, which sometimes makes it very difficult to titrate vasopressin. One of the benefits of this medication is no increase in pulmonary vascular resistance, making this a useful medication to treat patients who have elevated pulmonary arterial pressures and systemic hypertension. Second-line vasopressors include angiotensin II, methylene blue, hydroxycobalamin, and calcium chloride. Angiotensin II is a relatively new agent. It has short duration of action and may be superior in patients with acute kidney injury and patients taking ACE inhibitors and angiotensin receptor blockers in the preoperative area. Some of the side effects include thrombotic complications, and organ ischemia. Methylene blue and hydroxycobalamin have very similar mechanism of action via inhibition of nitric oxide and soluble guanylate cyclase. Methylene blue can lead to serotonin syndrome, pulmonary vasoconstriction, hemolysis in patients who have glucose 6-phosphate dehydrogenase deficiency or G6PD, hemodialysis machine malfunction, and skin discoloration. Hydroxycobalamin is not associated with serotonin syndrome. However, it can lead to acute kidney injury and nephrolithiasis. Also, skin discoloration, superior SLAP results, and angioedema and anaphylaxis have been described in patients receiving hydroxycobalamin. Calcium chloride is a ninopressor. It is quite effective, at least in the short-term management of vasoplegia and hypertension, especially in people who are hypocalcemic. Some of the side effects of calcium chloride include transient arrhythmias. Let's do a question. You're in the cardiac operating room managing a 65-year-old female status post-redo mitral valve replacement and CABG. Her outpatient medications include amitriptyline. She is currently off cardiopulmonary bypass but remains hypertensive with a MAP of 59. She has good cardiac contractility and adequate volume status on your assessment. She is currently receiving 0.3 micrograms per kilogram per minute of norepinephrine and 0.06 units per minute of vasopressin. Her ionized calcium is elevated and her pH is 7.38. Unfortunately, your hospital has a shortage of IV hydroxycobalamin. And what medication should be administered next to treat her hypertension and vasoplegia? Please pause this video if you need more time. If you have access to angiotensin II, I would encourage it to be used. However, if you don't have angiotensin II, the next medication to administer will be stress dose steroid, which we'll talk about in the next slide. We mentioned that unfortunately IV hydroxycobalamin is not available, and methylene blue in this particular patient is not a good idea because of your previous use of amitriptyline, and amitriptyline and methylene blue together can lead to serotonin syndrome. That is why methylene blue is not a good option here, and some of the possible next steps include angiotensin II and stress dose steroids. There are some adjunct medications which you can use to hopefully improve the blood pressure, including hydrocortisone stress dose, typically somewhere from 50 to 100 milligrams every 8 hours. Obviously, high-dose steroids lead to hyperglycemia, increased infection risk, and increased sodium. In patients who are acidotic, sodium bicarbonate can be used. The typical dose is 1 to 2 microequivalents per kilogram. And side effects include hypercalcemia, transient respiratory acidosis, and hypernatremia. Vitamin C or ascorbic acid can be administered, and some of the side effects include increased calcium oxalate excretion via kidneys and acute kidney injury. The proposed mechanism of action for vitamin C is increased synthesis of catecholamines and vasopressin. Natural history of vasoplegia is typically limited to the first 72 hours of cardiac surgery, and like mentioned earlier, unfortunately, refractory vasoplegia is associated with very high mortality. So in summary, vasoplegia is a common complication of cardiac surgery. Certain risk factors exist for vasoplegia. It is important to exclude other etiologies and use judicious IV fluids, vasopressors, and adjunct medications. If you have any questions or comments regarding this presentation, please feel free to email me on this address provided here. So this concludes this presentation. Thank you for your attention. I wish you all the best and good luck.